I'm Peter Squire, Account Executive at Health Data Movers. Today's webinar, you see the title right here, Unlocking M&A Success, Urging Systems for Seamless Integration and Maximum Impact. It's about what happens after the deal is signed, when it's time to make the systems work, support the clinicians, ensure data is accessible, reliable, and complete. So I'm joined today by two experts who are deep in that work. First is Dr. Haseltine. He's the Vice President and CMIO at Tidelands Health. He brings a background in clinical in both pediatrics and internal medicine and plays a key role in how Tidelands uses technology and data to drive better outcomes. He serves on advisory boards for several healthcare software vendors, including ECW, Meditech, and Highland. Alex Janssen is the delivery lead at Health Data Movers. He's a former Epic employee who's led some of our most complex data migration and integration efforts. He's been with HDM for over 5 years and is someone our clients really rely on to navigate technical and organizational challenges during these major transitions. For those of you less familiar with HDM, we are a healthcare technology services firm. We're the trusted partner for healthcare organizations through our services that are listed here: data management, integration, project management, and clinical and business applications. Our mission is simple: to empower patients and providers by unleashing the potential of healthcare data and technology. So today, Dr. Haseltine and Alex will walk through how effective system integration can drive success during and after M&A, and then Alex will share what to consider ahead of your next data migration project. Just a quick reminder before we get started, if you have any questions during the sessions, go ahead and drop them in the Q&A feature and or the chat. I'll be keeping an eye on them and we'll compile for our Q&A. Dr. Haseltine needs to drop off a bit early, so if you have questions specific for him, please send those in sooner rather than later, and we'll prioritize those first and save any remaining questions for Alex to tackle towards the end. So with that, I'll turn it over to Dr. Haseltine and Alex, and thanks again for joining.
Yeah, thanks, Peter. So kicking things off here with one of the most complex and foundational pieces of a system transition, we want to talk about data strategy and what's driving a lot of those decisions. So for this first question here, there are a lot of different ways that you can handle how you are moving data or not moving data from one system to another. So can you talk a little bit about what drove that decision?
Sure. We first looked at how the data would be used clinically. So is it just going to be a reference so you can look back at it, or is it actually going to need to be actionable so that it can satisfy health maintenance topics, quality measures, reporting data, things that you would need discrete data analysis for? So when we looked at it, we tried to decide, is the data in that discrete analysis form, or is it free text, which is really harder to transform and would lead towards more of an abstracting type strategy instead. So things like family history, social histories, for us, those were free texted into our old systems. They were very difficult to move, and we probably needed to go an abstracting route instead. Whereas when you look at lab data, which is very discrete data, easy to move, all well normalized ahead of time, it lended itself much more to a migration type strategy. Also, we tried to ask, is the data less frequently used, or is it older data, like several years out, in which we made the decision to archive anything that was really over 3 years? And then we also look at cost. It's expensive to retain all those systems and connect them, so we rather rapidly eliminated that route. We did decide to archive with a third party, and then we decided to migrate some data that we felt would be clinically useful. The other factor we had to consider was we had a really short time frame to do this in. We only had a year. And so, while there are experts like Alex out there, there are not a lot of them, and their time is limited also. And so there's only so much you can do with a year's time frame in which you have to do this. And finally, I think the last thing everybody needs to think about is there are always regulatory and compliance requests and requirements out there. So a lot of those are state or federally mandated decisions in which we'll say that you have to keep data, in our case, for at least 7 years for adults and 18 years plus 1 for children who are infants when they were first seen. So all those factors really go into deciding whether you're going to connect a system, migrate a system, archive it, or really abstract it.
Excellent insights. You mentioned that a lot of the data quality with some free text fields was particularly challenging when approaching it as a discrete conversion, which led to a lot of that abstraction effort that you may have done. Are there any other particular challenges with the data quality or integrating with systems that you previously used?
Sure. We had a number of challenges. One was the sheer volume of the data that we looked at. One of our systems had over 20 plus years, and we had not done a really good job of purging data according to those retention guidelines. So one of the things that we wanted to get out of this was a very good retention policy that actually followed the ones that we had in place. We had good policies, but we didn't always follow them. We also had a number of different systems. So we used 6 different systems down to 1. And so it was very difficult to try to decide, is the data laid out the same way in one system as it is in the other? And a lot of times they were not. And we had very difficult ways to figure out where they were even held in those systems, since they were held in many different places. And then, as we discussed, finally, that data is often not in discrete format. It could be in free text, and not only is it free text, but it could be in multiple areas of the chart. So it could be hidden in a note section someplace. It could be hidden in a family history section. It could be a little sticky note that was up on the side of the corner. So trying to decide where it was, how you could get it out, and the sheer volume that we had were all big challenges that we faced.
So when you're approaching that situation where you have multiple source systems that you're pulling data from and trying to determine what the best practice should be in your future state, or what should be the source of truth when we're converting data into a new system, how do you reconcile those differences between those two or more systems where there may be that crossover set of patient data?
Sure. Well, some of it, because it's large amounts of data and these are databases you're working with, if you've got a crack analytics team, which we had both on site and in terms of helping out with Alex's team, you can have them do some sort of automatic matching techniques. And so for large patient populations, we did that, but that really only gets you so far. And at some point, you're going to have to manually go through those things that fall out, and probably 10 or 15% of them are going to fall out. And somebody's going to have to actually look at it, manually decide. And in our case, even had to call up some of these patients and say, hey, we just need to confirm that you are who we think you are, and that you are in the same, in all 5 of these instances, the same person. And, they don't always match. Sometimes people have moved in different areas, or where they were 3 years ago is not where they are today. Their last names change as they get married. Their age may stay the same, but they may have reported a different age in one EMR, or somebody may have typoed it in the EMR as well. So a lot of things don't ultimately match, and finally you're going to have to go through a manual sort to try to figure out how well that matches up.
I imagine you got pretty familiar with your HIM team during that process.
Yeah.
So another aspect that was particularly challenging about the project we worked on was, rather than converting into a completely new Epic instance, this was a Community Connect install where we were migrating data to the already existing instance of Epic that was owned and maintained by MUSC. So approaching that challenge, what challenges were unique about that aspect of it?
Sure. Well, we actually shared many patients with MUSC, so we couldn't just load data indiscriminately. We really had to do a very thorough. Sorry about the dog in the background. But the existing system was in some areas up to date, but in some areas it was not. So we had to do some new build in order to bring it up to a current state. So things that we wanted to do could actually be matched in with the health maintenance topics. We also had to be very careful not to overwrite any of their existing data. And so that all really required a very strong governance in partnership with them, because there are going to be different views on what's valuable, how to manage the data, how to store the data, what needs to be stored, and their partner organization is going to know what they have much better than we would, for example. So it's really important to set all those goals out ahead of time, make sure you've got that good partnership developed, and also that you have a good process to resolve any sort of conflicts that are going to inevitably arise. And in large part that comes down to making sure that your philosophies are aligned. And to be quite honest, the philosophies of a large academic research institution aren't always aligned with that of a small community-based hospital. And so having those good partnerships in place, having those good process to work out the conflicts is really important ahead of time. And then having that strong relationship with your counterparts helps smooth the process quite a lot.
Sounds like change management plays a major role in these types of transitions.
Yeah, absolutely does.
So one point you mentioned early on was the focus on continuity of patient care and making sure that when we are migrating data, we're taking into consideration the value to the patient. Can you go into more detail about what other factors help inform your decisions when you're balancing that continuity of care aspect against other constraints?
Sure. Well, we, and I think most healthcare organizations will say that patient care always comes first. And with that in mind, you're going to have to set priorities around what your must-haves are in order to make a system easier to use at go live. So are there clinically actionable data points that you need in order to make those decisions that you're going to load and migrate? Is there data that will solve health maintenance topics like colonoscopies, mammograms, pap smears? That you need to move in discrete format and that you want to have migrated as opposed to sitting in an archive someplace that may not be actionable at all. Also, is there recent data that is going to be needed to use to make clinical decisions? So with that in mind, we migrated medications, allergies, labs. Now that's a lot of things, and people are going to have a lot of different opinions about what is valuable, what is prioritized. So it's really important to involve your stakeholders in your decision-making process, involve them early, involve them often, go to your subject matter experts as well to ensure that you're constantly on the right track. In order to do that, I remember we created and circulated documents about here's what we're going to move, here's the health maintenance topics we're going to satisfy, here's where you can find them, and here's how long we will be migrating them. In some years, in some instances, 3 years of data, in some instances, 5 or 7 years, and for colonoscopies, 10 years as well. And then it's important to kind of phase this transition strategically where you can. So let people know when the migration will be complete, when the archive will be complete, because those probably are two separate different time frames. And then have a decision around how long you're going to maintain the legacy systems and the new systems side by side, because that's going to be able to balance your financial pressure. Some of this for billing, you're going to need to continue to maintain those systems until your billing cycle completes its rounds. And some of it you're going to need to continue until you can archive, and sometimes you can't even start the archive process until you're completely out of the old legacy systems either. So having in mind what that phase transition is strategically will help save you costs in the long run. And finally, I think the most important thing is to provide really good training and support on where you're going to find the data and who is going to do what with the data. That does really reduce the amount of time spent and confusion that occurs at go live when people are trying to search for data where they're not sure where it's going to be. And in all honesty, excellent training can really overcome an average EMR build or minor deficiencies that everybody has in their build process. But poor training can tank even the best planning and migration. So, put another way, a driver's ed can really teach anybody to drive a Toyota successfully. But if you've got no training at all, you can crash a Rolls Royce. And our goal is to not crash a Rolls Royce with people's lives on the line.
With the emphasis on training and setting expectations with stakeholders and end users, so important to the success of the project, what other strategies did you use to help ensure, as things were in such a tumultuous time, that patient care delivery remained the center of clinicians' attention?
Sure. Well, we started this project with the idea that it would be clinically and operations driven and leadership driven from the top down, and not an IT driven project as well. So our CEO was involved from the beginning in terms of setting the mood, setting the tone. He was involved throughout in terms of making sure people were focused and on track. Our CFO, our COO, and our operations managers all played lead roles and were highly visible throughout the entire project. I remember, I think, Alex, you commented that you were surprised that I attended most of all of the data migrations meetings. But that's the philosophy that we had, is that we wanted clinical people involved. We wanted clinical leadership involved at every single point along the way. And it wasn't necessarily to be micromanaging, but it was just to make sure that you were aware that when questions came up that could not be answered, people were able to be there to answer those questions to make sure that the right clinical decisions were made. We also looked at doing thorough workflow mapping and testing of the legacy system so that we knew what our workflows were, because over time, what people were actually doing and what we thought we did were entirely different. And then we thoroughly did those new workflows in the new system to make sure that people could understand what the difference would be. So workflow mapping is really very important when in understanding what your old system is, what your new system is going to be. And finally, Alex, I remember with you, we did multiple validation rounds of the data with clinical experts. So we brought them in, we said, hey, does this look like what you expect to see? We did at least 3, I think, in order to make sure that they could get familiar not only with the product and the system, but also to make sure that the data quality was accurate. One of the phrases that we consistently used throughout the project was adopt and adapt. So most of what we used were tried and true workflows that had been tested in place from our partner organization. So if you can't do that and you're moving to an entirely new system, then consider either phased or piloted rollouts where you can do small rollouts first and then ensure that things are going well before we're rolling them out to a larger area. I think either way, one of the things to do is to really try to reduce customization, because it makes it more difficult on the long run when you've customized something that's entirely unique to you and might have worked great according to your old EMR processes, but doesn't really work with your new EMR processes. And that makes it even more harder to follow new EMR upgrades as you move along. Finally, we also looked at education, both standardized education in terms of we did webinars for people. We made sure they attended 4 to 8 hours worth of formal-based training. And then we also had informal-based training to where docs who were familiar with the system and had used it at different areas and had experience hosted training tips at their home, where people came over and sat down to dinner, and then they brought out their EMRs and sat down in a playground environment and said, okay, here are things that you can do to make your life easier as soon as you go live. We had 24/7 at the elbow support, and we also made sure that continued for about 3 to 4 weeks after go live as well when it was needed, and only cut back on that when people seemed to be well aware of the process. And then finally, we looked at real-time monitoring and feedback. So we had command setters that ran and had close tabs on all of our organizations and our metrics, and we really tried to figure out where are people stressed, where are they having difficulties, where can we deploy extra people to make sure that this is a better go live.
Yeah, that sounds like a complicated effort to coordinate. And I really appreciated when we worked together the leadership from the top that you referenced. I remember that there were a few particular goals or objectives that you wanted to accomplish regarding improved patient experience or outcomes for patients during the system transition. So can you talk about a few of those and share how you measured whether those were successful?
Sure. So our overarching goal, and one that we had had for years, but just had not been able to get to until we did this, was to have one record, one chart, one experience for the patient. And so when we took the 6 EMRs and combined them all into one, I think we made a significant amount of progress in that and moving forward with that. We had a large number of KPIs that we knew in terms of monitoring our data from the year before, what our baseline was. And so we used those as baseline measures to compare afterwards to monitor things like, are colonoscopy rates going up, or did they drop down once we went to the new system? Are rates of mammograms going up, or have they dropped down after we went to the new system? Are we still having patients left without being seen from the ER in the same time that we had before, or is that improving? So we also listened to feedback from clinicians and patients in terms of surveys, and then tried to address in as rapidly as possible what the results of those feedback surveys said.
So in those feedback surveys or other feedback that you received, were any particular challenges discovered as you were going through these enhancements to clinical workflows or care quality?
Sure. I think people wanted to continue to do work the old way that they had, and so they had trouble adopting a new system. A lot of them didn't fully understand, and myself included, how the system worked ahead of time. And that meant that even though we had migrated data that we thought would be best practice, There were some health maintenance flags, for example, that still had to be manually set afterwards that we had missed just because we didn't fully understand what we were getting or how to use it. We found that there was increased time for reconciliation and for abstraction. We had planned on initially just doing about 1 month's worth of abstraction work, but we found that due to the way that we had migrated some of the data, it was actually taking a lot longer to accomplish things that we expected. And so we extended abstraction out for 3 months. And in some areas in oncology, we even ended up needing to do it for a full year based on their history and their workflows. One of the things that we did and problems that we came up with, we had moved from 5 different systems, 5 different medication lists. And in hindsight, that was probably not the best thing. I wish we had chosen one medication list from probably our outpatient list and just said, this is the best list possible that is most up to date, and migrated that. We found out that after we did the move, when we had 5 of the same medications and discontinued 4 of them, well, the MR sent those discontinuation notices to the pharmacy, and then the pharmacists thought the patients should not be on medications that we really needed them to continue, in addition to having nursing staff spending extra time, canceling out and reconciling very large and lengthy medication lists. So in hindsight, had I known how the system worked better, had I understood perhaps a little bit better, we would have just migrated 1 list instead of 5 in many of those areas. It also took increased time, I think, for us to do lots of things, especially on the archival standpoint. We had hoped to be ready to go live, but it's taken us probably an extra year just to archive the data. So there are certain notes that, in hindsight, I would have migrated directly into the EMR, probably the last note. We had made the decision not to migrate any old notes at all. So I probably would have migrated 1 last note, so there was less of having to refer back to extra live systems and legacy systems and then copy and paste into the new EMR. And finally, I think those feedbacks and surveys consistently said our training was not as good as it should have been. So I wish we had probably spent more time training, more time developing training. We did go back through and revamp and re-educate and retrain most people about 4 to 6 weeks afterwards. And we continued to do ongoing training and self-development, having stood up a new Workday learning system in order to manage a lot of that process.
So earlier you mentioned that there were a lot of financial considerations that we had to balance as we are going through things, like timeline of only having a limited time in order to migrate this data. But when you were looking at the project as a whole, what operational efficiencies were you hoping to achieve by making this system transition across the various applications?
Sure, yeah, we really wanted that 1 chart, 1 record. So having those 5 or 6 different electronic medical records to begin with meant that providers were really siloed and made clinical decisions in a vacuum without having a full picture of what the patient actually looked like. They would see their own piece of the pie and not everything else. So you really only get improvement in health maintenance outcomes when everyone can work on the same problem within the same platform. So for example, if you take colon cancer screenings, the primary care doctor was ordering a colon cancer screen in their own EMR, but then the GI doctor was doing the colonoscopy in a separate EMR documentation. And then the oncologist who picked up later when colon cancer was found was in yet a 3rd EMR. So all of those data screening results were in 3 separate EMRs. It was very confusing. Nobody had insights into what the left hand was doing from the right. And so we wanted to get everybody working on the same problem, the same patient, the same place, the same results, so that we all could agree on how best to move forward with the best amount of patient care. Finally, in revenue cycle, we needed 1 bill to be easier, less confusing for the patients, instead of sending 5 or 6 different separate billing statements out. And also it ended up being much less work for staff when you're just working out of 1 system as opposed to trying to collate and figure out what the financial responsibilities are of a patient in 5 different systems. We also end up having greater insight into data across all areas of the payment cycle when it's all in 1 place, and that really drives efficiencies in collection. And these days, in the current financial constrained environment that healthcare is in, you really need to have everything in 1 place in order to have efficient, effective collections.
So despite the major effort of migrating everything to 1, it ended up resulting in a big payoff in the increased efficiency with your revenue cycle management.
Absolutely. It does take some time to get back to your baseline because everybody's getting familiar, getting used to the new system, and there are always some bugs and errors to get working out. But we are now seeing collection rates that are above where we were when we started.
That's an important data point to recognize and a good reason for why we do things like this. So earlier you mentioned the training challenges that you faced during this process. Were there any other operational pain points that came to light either before or during or after the go live? And how did the team come together to resolve those?
Sure. I think the medication issue where we migrated too much was an issue, and we pretty much had to brute force our way through that. We added extra staff where we could in order to help reconcile things. We did extensive training so people understood what would happen and how to do that. We also didn't migrate that last note, which led to having to refer back to legacy systems. So I think I would have done that ahead of time. As we talked about, the training was inadequate. We recycled back through, rebuilt that program. There was an increase in the abstraction time, so we leaned heavily on your team to make sure that we had additional abstractors that we could use as long as clinicians felt comfortable needing them. So we extended those dates out from that initial 1 month to 3 months, and in the one oncology area of the organization out to a full year. But finally, there were those governance issues that we needed to have some heart-to-heart conversations sometimes with our partners on the other side so we could come to agreement on where we needed to be. And so making sure that we had those plans ahead of time and that everybody was on the same page. And altogether, I think those issues working through make sure that we've got a stronger process, both in terms of partnership for your patients. I feel much better in terms of how we're working hand in hand with our partners now on the other side, having gone through this process. And very much appreciative of all the work that everybody's done, both with our partner organization and with those organizations that help get us to where we are today in terms of doing the migration.
You mentioned several KPIs that you used to track success over the course of the project. So taking a step back and looking at like overall measures of success that you used, can you share a little more about what those were?
Sure, and I think where we started out was we wanted to use dashboards at a much greater frequency. We knew with our new EMR system that the reporting capabilities, especially with real-time reports, was much better than we were able to do in the past. A lot of times in the past, our older systems, we could run reports, but we would give them to people a month, 30 days, 3 months later, and that's not very actionable information. The new system would allow us to, on real time, focus on data metrics and try to solve those things where we could. So we tasked every department with identifying 3 to 5 metrics to focus on. We made sure that we had at least baseline data for those 3 to 5 metrics from the past year so that they could identify where they started with. And then we created those real-time dashboards that they could look at and go live so that they had the baseline they could look at, they could see what they were doing in real time. So some examples of the things that we use occupancy metrics, for example, in terms of beds. We looked at time spent in the ER. We looked at patients who were left without being seen from the ER. We looked at the time it took to get a patient through the entire process, both from admission, from arrival to the ER to discharge from the ER, and from admission to the hospital to discharge from the hospital. We looked at registration time and gave quick feedback to people in the registration desks at how long it took them to register a patient. We looked at our payment collection rates. So, how much are you collecting at the time of service when the patient's there in front of you? How much are you having to rely on later on, 30, 60 days, 90 afterwards? We've looked at how well people responded to patient calls in the outpatient area. So could you respond to them in 24 hours? What was the rate of doing so? We are now at the point that where we're able to say, hey, these offices look much better than others. How can we help share that information from one office that's doing a really good job to one that seems to be having more difficulty? And we can even go to that the office and try to figure out, what are the challenges that you're having at this one office based on your KPIs that look worse. So how do we need to shore up areas and help you out in those areas?
So to that effect, can you talk a little bit more about the process you used to kind of dive in past the initial analytic data and see what the root cause was of some deficiencies that you may have seen?
Sure. We mainly ask the managers because they're the frontline people who know their areas best. So yes, I can take a big 360-degree look at it, but when it comes down to the actual workflow and the actual process, it's going to take somebody on the ground in that area who's familiar with what's going on, who can dive into that process. So we really looked at pushing information, data points, KPIs down to line unit managers who could take those and actually act on them as well. So we have people in registration, for example, who figured out that we weren't doing a very good job of asking for collections at the time that patients were being seen. So they came up with an entire process on their end to re-educate, retreat people, or retrain people so that they understand the collections process, they understand the need and the importance of collecting at time the patient is right in front of you, and they understand how to ask it. So sometimes it's not a matter of saying, would you like to pay today, but how are you going to pay today? And that increases your collection rate at the front end. So really, and that's not something that I, as a practicing clinician, usually see. I'm usually on the back end, either looking at data or I'm sitting with a patient in the middle office. I'm not at the front desk and having those ideas. So really tasking front end managers in those areas, giving them the tools to be able to make their decision and the data to be informed with that decision is highly important.
Excellent points. All right. Well, Peter, do we have any questions for Dr. Haseltine before he has to run?
Not that I see. If anyone has any, feel free to use the Q&A feature. Dr. H, I guess I'll kick us off. Just one quick question. Other health systems that are considering this migration or this change similar to what you all went through, what's the first sort of level of advice that you would give them?
Yeah, I think have a plan and then be able to roll with the punches as they move. So once you've got your plan, you've considered how to do your data migration strategy, then you can move forward. And then we relied on a number of partners to help us get through that plan because we weren't always aware of what it would take to do what we wanted to do. So as long as you've got the vision, bring in the experts to help you in terms of making that vision a reality.
Yeah, Peter, I think one of the most important elements when you're tackling a big system transition like this, Dr. Haseltine mentioned several things that they learned over the course of the project. So just working with folks who have done this sort of thing before, who aren't encountering things for the first time, can really make a big difference, and their expertise can help avoid some issues that you may have otherwise seen.
Perfect. Thank you. Any other questions? No. Dr. H needs to jump off.
Appreciate it. Thank you for having me.
Yeah, thanks so much. Really appreciate it. And Alex, I think we're going to continue with you and you go through some other talking points here.
For this next section, I've just prepared a small checklist of sorts, walking through some of the most common and important aspects of a data migration project as you are considering a system merger reconciliation. So we can go through those. I'll talk a little bit about them. And if you do continue to have questions, feel free to use the Q&A feature or drop them in the chat. So we talked a little bit about this earlier, but when we're looking at strategic and financial considerations for a system migration, one of the most important elements is to first look at the greater picture as a whole and assess your overall direction that you want to take as an organization. One of the things that we like to do is to do inventory of all of the data types and systems and work with stakeholders who are closer to those data types to make that decision that Dr. Haseltine mentioned earlier, where you're seeing which data needs to be archived or migrated or converted or abstracted in some cases. And one of the factors for that is how long your legacy system is going to stick around after you go live with your new system. And then, of course, you have overall cost and timeline and regulatory requirements. Moving on to the next major category. It's talking about how you want to approach data as a governance committee. Well, first of all, one element that you should definitely do if you're considering a data migration is to establish a data governance committee, because there are too many times where I've seen projects that do not have a specific body that is overseeing or responsible for data strategy during one of these transitions. But aside from that, knowing what the most critical data elements are and evaluating it from a technical perspective to see how feasible certain elements are to convert discretely. Like Dr. Haseltine mentioned earlier, family history might be free text, or there might be elements that will take an inordinate effort in order to convert as opposed to other methods. So you want a governance committee to help drive some of that decision making from the top. Moving on, we have technological considerations. And for these, you want to work closely with your IT and network and hosting team, firewall folks who may have a more intimate understanding of your system's IT infrastructure. And there may be cost considerations to determining what model you're using, if you're hosting it yourself on the premises or using a hosted model, and want to confirm that all of the data is being kept securely and firewall ports are opened up between your system and any ancillary systems that you're integrating with. And lastly, we have operational and clinical considerations. So, as Dr. Haseltine mentioned, training is such an important element of these types of system transitions. And one thing that is particularly helpful in that regard is to help champion the effort by elevating certain folks to be super users that can help guide their peers and really help push the effort of training everyone forward from within. Other than that, I will now go to any questions that you may have. I do not see any at this time. All right, well, if anyone does have any questions that are burning a hole and would like to reach out privately, you can contact us here and we'll get back to you on this.